Mesdames, Messieurs, bonjour. Je vais donc ouvrir cette séance qui est un peu exceptionnelle, puisque nous accueillons aujourd'hui, l'Académie de chirurgie accueille aujourd'hui l'American Surgical Association. L'American Surgical Association est la plus prestigieuse, la plus ancienne, la plus prestigieuse des associations de chirurgie américaine. Et je dois dire, pour ceux qui connaissent cette association, c'est certainement dans le monde l'association vraiment la plus prestigieuse. Alors je voudrais appeler tout de suite son président actuel, Timothy Eberlin. Please, Timothy, may you come here, just near me. Et merci. Et pour ne pas être trop seul ici, est-ce que je peux demander à Jacques Beaulieu, vice-président, de venir ici également, ainsi que Henri Judet. Jacques Beaulieu is the vice president. He will be president next year. And please, Henri Judet is the general secretary. And je voudrais aussi appeler le secrétaire de séance. Non, pardon, attends, je m'excuse. Tu peux rester là parce qu'il y a L.D. Bwitt, qui est le futur président de l'American Surgical Association. De toute façon, je vais vous présenter tous les membres tout à l'heure. Alors, je vais tout de suite commencer cette séance en les présentant. Donc, il y a donc près de moi Timothy Eberlin, qui est donc actuellement, comme je vous dis, président de l'American Surgical Association. Il est aussi membre de l'Institut de médecine de l'Académie nationale des sciences aux États-Unis, qui est un titre prestigieux. Et il est chairman du département de chirurgie de l'Université de Washington, Saint-Louis, Missouri. Donc, Timothy Eberlin, ici. Alors, je vous demande d'attendre pour applaudir. On va présenter d'abord tout le monde, je dirais presque comme ils le font eux-mêmes à l'américaine. Ici, il y a L.D. Bwitt, qui vient d'achever sa présidence de l'American College of Surgeons, qui est la grande institution américaine, qui est beaucoup plus large, où pratiquement tous les chirurgiens américains sont inscrits. Je crois qu'il y a 40 000 membres. Et c'est en plus le futur président de l'American Surgical Association. Il est professeur et chairman du département de chirurgie de l'Eastern Virginia School à Norfolk, Virginia. Voilà. Alors maintenant, je vais tout de suite appeler les autres. Il y a le professeur Donald Trunke. Donald, yeah, please. You come and you see in front, looking at the audience, for you have taken by the camera here, the video, and then I present all of you, and then after we applause as you did yourself. Il est donc vice-président de l'American Surgical Association, professeur et chairman du département de chirurgie de la Science University à Portland, Oregon. J'appelle également Joe Fisher. Joe, please. Passe vice-président de l'American Surgical Association, chairman du département de chirurgie du Beth Israel Medical Center in Boston, et il est maintenant le McDermott Professor of Surgery. Il a également reçu le médaillon d'or, qui est une décoration très exceptionnelle de l'American Surgical Association, le médaillon d'or de l'American Surgical Association. Je fais une parenthèse parce que nous avons également dans la salle un autre gold médaillon, qui est François Dubois, un des rares, peut-être même le seul Français qui a eu cette distinction extrêmement prestigieuse. François Dubois, he received the gold medallion of the American Surgical Association. And François Dubois is with here today. Then we ask Ronald Busutil, qui est aussi passe vice-président de l'American Surgical Association, professeur et chairman du département de chirurgie de l'University of California, Los Angeles. Merci, Ron. Tom de Mester, where is Tom? Please, Tom de Mester, passe vice-président de l'American Surgical Association, professeur et chairman du département de chirurgie University of Southern California, Los Angeles. Nous avons donc les représentants des deux UCSD, UCLA, ici. Ensuite, Courtney Thompson. Courtney, please. Passe président de l'American Surgical Association, professeur et chairman University of Texas, Galveston. Timothy Billiard, here, chairman du département de chirurgie University of Pittsburgh, Pennsylvania. Et le dernier, c'est Lee Swanson, qui parle parfaitement le français, qui est passe-président de la Sagesse, qui est une grande institution de l'endoscopie américaine, professeur de l'Oregon Health Science University à Portland, Oregon. Si vous voulez bien, nous allons tous les applaudir. Merci beaucoup. Si vous voulez bien, je vais maintenant m'adresser à nos collègues américains qui ont traversé l'Atlantique pour venir nous voir et pour leur souhaiter la bienvenue dans leur langue. Presque. I would like to welcome you here at the French Academy of Surgery. In order to be frank, it is not our usual place. We have another place, but the room is not so large, so we decide to be here. So this is why we have some difficulty for the management of the screen, of the camera, and so on. So only some word of history. The French Academy of Surgery was founded indeed in 1731 by the King, Louis XV, and the problem is that 50 years after, in 1793, under, I think, the rule of Danton that we see just outside the statute, the revolution, the French Revolution, decided to suppress all what is royal. And the Royal Academy of Surgery disappeared. But in 1843, that means 50 years after, we reappear as the Society of Surgery of France. And in 1935, at the end, we recover exactly our name, Academy of Surgery. So we start in 1731. It was not so easy to remain. I know that the American Surgical Association was founded in 1880, but luckily you were always the same in the same continuity. So we have different fortune, but I think it is like this. It is life. So after this short presentation, I will open the session. I'm sorry, I have a ring here, and the ring was forgotten some part, but usually there is a ring, so no ring today. And this session will be devoted to, no, I must say that we organize, for you 10, or you are 10, we organize 3 sessions. For usually our session is 5 to 6 talk, no more, and half are member of the French Academy. So we decide to organize other session, not in Paris. And the second one will be tomorrow in Lyon. And we are lucky for the Vice President, Jacques Beaulieu, is a key surgeon in this beautiful city of Lyon that you will see tomorrow. And after tomorrow, there is another session. Always, they are called common session of the French Academy and the American Surgical Association. So we have 3 common sessions altogether. The last one will be in Nice. And at that time, all of you will split. But today, only, I may say, unfortunately, 2 of you will speak in front of the, I will say, the academician in Paris. So, you want to say one word? Okay.
On behalf of the American Surgical Association, I think it is an honor for all of us to represent our organization here, the Academy of Surgery, France. We look forward to not only the interaction over the next 3 or 4 days and appreciate Professor Bismuth's hosting the group of us here in Paris and Lyon and Nice and Dijon. But we also look forward to establishing a closer relationship. The world has become a much closer place, and France is playing an ever important role in the world's economy, and the partnership along with the United States is something that happened in the past, and I think is going to hold us in good stead in the future. And I think a similar analogy would be true for surgery, as the contributions in France and the contributions in the United States collaborate more closely and establish a closer relationship. And we look forward to doing that over the coming years. So thank you.
Thank you. Bien, nous allons donc ouvrir la séance maintenant, et je vous demande d'avoir vraiment une discussion, nous avons du temps pour la discussion, n'hésitez pas à poser votre question, et à tout seigneur, tout honneur, le premier orateur est donc Monsieur Timothy Berlin, present your speech, et il va donc présenter les cancers du sein, nouvelles stratégies contre un vieil adversaire. Et nous avons un intervenant à qui je donnerai la parole en premier, qui est Rémi Salmon.
Again, it is a real honor to be a part of the French-American Surgical Academic Week, and I thought I would give a little overview of a subject that has been dear to me over the last several decades, and that is the study of breast cancer, and blend a little bit of what we've done in the laboratory as well as clinically. The history of breast cancer dates back to the Edwin Smith Papyrus, and it was actually back in the 1800s. One of the most vivid descriptions of a radical mastectomy was from here in France by a then poet and author, Fanny Burney. She was the spouse of Baron Dubois. And it was Napoleon's surgeon, Baron Larrey, who performed the radical mastectomy. She was diagnosed with a breast cancer. And this, of course, is in 1811. This actually happens to be a woodcut from Pancoast in 1844, but before general anesthesia, before antisepsis. And her description, quite vivid and somewhat horrific, was really the state of the art through the 19th century. And of course, then progressed with radical mastectomies, which led well into the mid 20th century. It was really at about the time I finished medical school and residency that a large number of organizations around the world did randomized prospective trials, and these are the original trials led by the Gustave Roussy here in France, as well as the NSABP in the United States and Milan and other international organizations that showed that breast conservation was and radiation therapy was as good as a mastectomy. And the state of the art at that time was that Early breast cancer could be treated with breast conservation radiation in contrast to a mastectomy. The first questions that we asked was what were the rules to govern selection of patients for breast conservation? Because at the time, in the mid-'80s, patient preference was probably the most common reason for a patient to choose mastectomy. Of course, diffuse disease, medical contraindications such as collagen vascular disease. Even now, our radiation oncologists are quite liberal about treating patients with scleroderma and other collagen vascular diseases with radiation therapy. Early pregnancy, probably the most common reason was anticipated poor cosmetic result. That is, the surgeon felt that the cancer was too large to be removed with breast conservation. And I've also listed accessibility to radiation therapy because that, especially in the United States, was not uniform in the mid-1980s. So the first question we asked was, what was the influence of tumor size on local recurrence? And we, in a study that had almost 900 patients, we segregated patients into 1 centimeter increments and showed that whether the patient was ER negative or ER positive, that there was really little impact on the rate of local recurrence. ER negative tumors being somewhat higher local recurrence rate than ER positive tumors. The next observation that we made was that older women tended to have lower recurrence rates. And our hypothesis was that they had more radical resections. Breast conservation, but more radical resections. When we studied the size of tumors, we did find that there was a correlation of an EIC type of tumor, that is an extensive intraductal component. And there, it didn't matter what size the tumor was, 1 centimeter or 4 centimeters, if you had an EIC component, that is extensive intraductal disease, along with the infiltrating tumor, the risk of recurrence was higher and would require, therefore, our hypothesis, a more radical resection. So with those two pieces of information, older patients had more radical resections, lower recurrence, and EIC positive tumors required more radical resection. We asked the question about size of excision and local recurrence. As you can see on this slide, it's a busy slide, but EIC positive tumors tended to have a much higher risk of local recurrence with radiation therapy compared to patients that had EIC negative tumors. More importantly, the size of the resection was much more important in the EIC positive tumors. That is, the larger the resection, the lower the local recurrence rate, and that was statistically significant in contrast to the EIC negative tumors. So that led us to the next question, which obviously was important, and that is margin status. And as you can see on this slide, and is now well documented, patients that had negative margins had very low risk of local recurrence with radiation therapy. And looking at all comers, patients who had positive margins had a much higher risk of local recurrence. However, when we looked at the margin of the resection, even small margins had a relatively small risk of recurrence, and even less than a millimeter with radiation therapy, it was still relatively small. somewhat surprising to us, and again, all of these tumors were reviewed by a single pathologist who was blinded to the outcome of the patient's results. And we found that patients who had focally positive tumors had an increase in the risk of recurrence, but not substantially. So it went up from 3 or 4% to 9%, and a lot of patients would accept that risk of recurrence. Certainly if you had more than a focally single area of margin positivity, it was unacceptable even with radiation therapy. Of course, there are some patients who have diffuse disease, very large tumors, etc., that are clearly not the candidate for breast conservation. And we would did a study with immediate reconstruction. And the immediate reconstruction using breast reconstruction, particularly in women who had nipple-sparing type of operations, had little morbidity, no risk of increased recurrence, which was one of the major suspicions, that particularly with tissue transfer reconstructions, and there was no interference with subsequent systemic treatment, be it chemotherapy, radiation therapy, and again, these are studies that now have led to confirmatory studies, and yet we had very excellent cosmetic results. Now, in the mid to late 1990s, David Craig and Armando Giuliano and others did sentinel lymph node biopsy as an alternative to axillary lymph node dissection, and the technique was using either a blue dye or perhaps a radio-labeled sulfur colloid, or the combination of both, which was able to detect these sentinel nodes. Over the last number of years, institutions like ours have used a combination of ultrasound and fine needle aspiration to be able to detect sentinel nodes, particularly in patients who have large tumors. And this is the normal morphology on an ultrasound in the axilla as compared to an abnormal ultrasound and doing fine needle aspiration. We asked the question about developing a completely new technology and perhaps avoiding sentinel lymph node biopsies in women who had early breast cancers, because as many of you find in this audience, women with early breast cancer have a high risk of having negative sentinel nodes. And if we could avoid a general anesthetic, one of our colleagues developed a photoacoustic imaging using a contrast agent. This is actually a combination of laser wavelength and ultrasound detection. And using that combination, we can detect very small amounts of tumor in lymph nodes and do this in vivo in the patient. In some early stage trials, this is work from a biomedical engineer at Washington University, Li Hong Wang, who does work with our breast surgeons, and you can see here's a photoacoustic image of a sentinel lymph node, and you can see the exact same lymph node as a blue dye, and he has been able to show that even lymph nodes deep in the that are small can be sampled without excision, but with a core biopsy. And so we're actually doing a clinical trial now comparing sentinel lymph nodes removed and excised with an anesthetic to sample with a core needle biopsy, but detecting it using photoacoustic imaging. One of the advantages I think that surgeons have in breast cancer is performing neoadjuvant studies because you have access to tissue and are able to participate in clinical trials. In our cancer center, the surgeons actually do about 30% of the therapeutic clinical trials in our cancer center. This is a study in ER-positive postmenopausal women. It's an ACOSOG cooperative group, American College of Surgeons Oncology group. It was actually led by one of the medical oncologists in our institution, comparing different aromatase inhibitor therapy as a neoadjuvant. This medical oncologist, Matt Ellis, developed a prognostic index including Ki-67 and ER positivity, as well as tumor size and nodal status. What we have done is done whole genome sequencing on a sample of these patients, looking at the non-responders that still have high Ki-67 versus the sensitive tumors, low Ki-67, to determine which mutation and mutational patterns between those two groups exist. What we have seen clinically, however, is that aromatase inhibitor neoadjuvant therapy, these are what the surgeon felt. These were not candidates for breast conservation, but as you can see, in marginal patients, 83% ended up with breast conservation, and even in the patients who were felt to be inoperable before therapy, inoperable even with a mastectomy, 75% of those patients ended up with breast conservation. So a very high degree of patients respond. We've now put together multidisciplinary teams to look at early stage breast cancer. There's ductal carcinoma in situ, as well as the stroma, invasive breast cancer, as well as women that are at high risk but do not have BRCA1 or 2 gene mutations. So these are patients with very high family histories of breast cancer but do not have BRCA. And we do this in combination with our Genome Center at Washington University. This is an example of a patient who had triple negative breast cancer, ER negative, PR negative, HER2/neu negative. And here we developed a xenograft model, which we've used in other settings, primarily to look at the gene mutation and pathways. And we've shown that actually a xenograft model is no different than the primary tumor. And so it affords us the opportunity to study these tumors in vitro. These are human tumors in a mouse model. We finally put a group together that we call the Bright Institute, which is bridging research in imaging. Because as you can imagine, looking at these gene mutations in breast cancer, and by the way, we do this also in lung cancer and pancreas and prostate, endometrial cancer, and glioblastomas. And we're looking at molecular markers, which we can use diagnostically in early breast cancer. Finally, over the last 20 years, I've looked at the immune response to malignancy in a number of different types of tumors. And of course, the holy grail of a vaccine is to be able to identify a mutation that is unique to the malignancy and distinct from the patient's normal immune structure. And so we've been able to do that with our whole genome sequencing because we're able to pick out mutations that are completely unique to a patient, and using a DNA vaccine, we can put these mutations in. And so we enroll patients doing their sequential biopsies, do the mutational analysis, grow the vaccine in a GMP facility, and then vaccinate the patients. And so this trial is just opened. We've actually are completing a trial using mammoglobin, which is not a unique vaccine. They show the proof of principle of this type of technology. But now we're just about to open a trial using these gene mutations identified by whole genome sequencing. So in summary, I think we're developing a completely new, different type of diagnostic and personalized treatment strategies. They build on the previous clinical studies where we showed that breast conservation was as good as a mastectomy, and we're now pushing the envelope, trying to do less surgery and more multidisciplinary care. The way that we're doing that is through photoacoustic imaging, where we have clinical trials ongoing, whole genome sequencing, where we've integrated with basic scientists, cell biologists, geneticists, and bioinformaticists. And we've now developed what we think is a unique breast cancer vaccine, and that will lead to more and better personalized care for the breast cancer patient. So again, thank you very much for your attention. I'd be happy to take any questions.
Thank you, Dr. Eberlin. The paper is now open for discussion, and the first discussant is Dr. Salmon, please. Dr. Salmon, you have the microphone. There is a microphone in the room, please use it. Normalement, il doit marcher. Il marche pas.
Well, Dr. Eberlin, it's a great honor and great pleasure to be the first discussant in front of some people who have taught me surgery. As probably you experienced the same thing at the beginning of your surgical experience. Breast surgery was some kind of minor surgery in comparison with GI surgery, esophagus surgery, rectal surgery, and so on. But when we listen to your presentation, we discover that under the fact that breast cancer became a real nationwide problem, because it's about 300,000 breast new cases every year. In France, it's 52,000 new cases every year. You just demonstrate that you are first a surgeon. Obviously, if you aren't, you won't be here. But you are also a biologist. You are a mathematician, statistician, able to design prospective randomized trial, probably psychologists in some way to explain to the patient how to participate in a trial or not. You are concerned by aesthetic problems. You are a statistician, an expert in imaging, and also very brand new things in physics with your new tool for axillary imaging. So if you measure the distance between the 80s, when we are just removing mastectomies, large axillary dissection, looking at our swollen arms, a little sadly, but knowing nothing to do. And when we hear you, we measure how far we went from these years. So, in fact, I have two questions. The first one is, and you didn't, well, you cannot cover everything, but are you reoperating the positive sentinel node biopsy? That's the first question. And with your new imaging tool, are you going to use it in doing sentinel node biopsy before neoadjuvant chemotherapy?
Thank you very much for your kind comments. And Let me take the very first question. We're finding, as you all know from both the ACOSOG trials as well as the NSABP trials, that doing axillary lymph node dissection is not necessarily that important, particularly in terms of long-term survival of the breast cancer patient. And what we've done locally in our own institution is determine the amount of tumor that is present and the location of the tumor in the sentinel node. So if there's only a few millimeters of tumor, then I think we're less apt to do a reoperation and axillary lymph node dissection, particularly if the patient is going to have breast conservation radiation, because that patient frequently can have low axillary radiation in the port, and their risk of local recurrence is probably no greater than the patient having a reoperation, another general anesthetic, but having an axillary lymph node dissection. The second question is, yes, we do photoacoustic imaging. The study we're doing now is actually comparing sentinel lymph node biopsy by standard blue dye radiocolloid combination. That's what we find to be the best, and see if we're able to detect the lymph node first by doing photoacoustic imaging. The idea is that if we can show with relative certainty that we can identify the sentinel lymph node, we would hope that we would actually be able in early breast cancer, so not patients with stage 3 or 4 breast cancer, but in early breast cancer, really avoid sentinel lymph node biopsies. Which again, if you think about that, we'd be able to treat a majority of women probably with local or standby anesthesia and avoid a general anesthetic that now is required with the sentinel lymph node biopsy. So that's where we're going with the photoacoustic imaging technology. So thank you again for your comments.
Thank you. Any other question on this topic, which is an illustration of what we need to do? Stronger the attack, stronger will be the defense. And this is a general rule. It is not enough to be only one opponent. We must be many. And this illustration, I don't speak about the breast, but in liver, it is the same. When we have tumor liver, surgery is not enough. And now we need what we call neoadjuvant and adjuvant treatment, more and more adapted, personalized, as you say, target on the tumor.
Well, I think the reality of doing the sequencing, we're already beginning to make an impact in patients that we've done sequencing in lymphoma and leukemia, the liquid malignancies. But already, for example, in the ACOSOG trial that I just demonstrated, we're able to pick out, using gene sequence, patients pre-treatment who are going to respond or not respond to aromatase inhibitors. And of course, the real help, which will help in liver tumors, is to be able to predict those that will respond to various treatments, adjuvant or neoadjuvant chemotherapies, as well as identifying new treatments, because as we study these pathways and which genes are mutated or deleted, we're able to either modify the pathway or utilize an alternative pathway and identify a targeted agent. And so there are some targeted agents that we're beginning to experiment with. We have a couple in medullary carcinoma of the thyroid, for example, and the hope would be that we'd be able to extend that with other tumor types as well.
Merci. Pas d'autres questions? Je pense qu'on peut poser des questions en français. N'hésitez pas et on traduira. Oui. Attendez, prends le microphone. Pour deux raisons. D'abord parce qu'on ne t'entend pas, et deuxièmement parce que tout est enregistré. La séance est filmée, je vous rappelle.
I appreciate very much your talk. Does in your country systematic screening of women organized, and what is the way it's done?
Well, you probably know it's relatively controversial. The American Cancer Society still recommends screening mammography over the age of 40, at least on an every other year basis. Although in prospective trials, because of the intent to treat methodology for analyzing those trials, it's been difficult to show statistical benefit of doing screening. We can clearly show that we save lives, but the question is it balanced by the cost of the screening mammography, particularly when in the United States our collective healthcare bill is $2.4 trillion this year. So, however, what we can show, since we've been doing screening mammography, is that the size of the breast cancer upon diagnosis, so just in the mid-1980s, the size of breast cancer was about 3.8 centimeters, almost a 4-centimeter tumor, and now they're about 2.3 centimeters, getting smaller. That's a 50% reduction in the size of breast cancer. And I think a lot of that is due to the screening. The question again is the cost-benefit ratio, but screening can benefit and save lives, just the way we can with colonoscopy and other types of screening methodologies.
LD Brit, please, a question?
Eveline, somebody whispered to me when I got here, with ESOCOG and all the clinical trials that the American College of Surgeons and obviously the American Surgical participating in, some of our French colleagues asked how can they be an alliance, an ally, partner in some of those clinical trials? Can you give them some sort of feedback?
Well, actually, there are opportunities for international participants, and particularly, for example, in the ACOSOG trials, the vast majority of patients who accumulate to the trials are actually not from the large academic centers in the United States, but they're actually from relatively small institutions who are thoughtful about the patients that they treat, and so there would be an opportunity for clearly international participation in those trials.
Any other question?
I have an answer for the reason why we don't participate. It's just a matter of insurance, because the prospective randomized trial have to be insured, and the French insurance company doesn't cover American trials.